So I don't know what I need to do to make sure that he's okay. I don't have you in here at all. Just his tumors.
Yeah. Got that there?
Yeah, I got it.
Yeah. So that's
Okay,
it
so
there.
that's,
So this is looking from the side.
yeah.
This is looking from up. So this is as
Okay.
if we're looking from the feet up. So
Alright.
feet here,
All
head
right.
behind the screen, face here,
And this is it right
back
there.
here.
Right
And
there,
it's,
right?
no. That's the spinal cord.
Oh,
so
okay.
it's actually here. It's
How old are you, Doc?
this here.
Okay, I see
It's
it.
there.
I see it.
So, and then this here is, and then this is it right here.
That's the tumor.
This is the tumor itself.
Oh, that's pretty big.
Yeah.
It's
This is the
very
spinal
big.
cord here. The white is the fluid around the spinal
Okay.
cord. And then this is the, and that's the bone here.
So it's cutting off all the blood flow and everything to the
So
nerves.
this thing right here.
Yeah, I can see the spinal cord right here.
So this, yeah, this is, so this black line, that's your spinal cord there.
Okay.
That's your brain there. The white is the fluid normally around that.
And this is the disc right here. Those are discs.
And this is the, yeah, this is a disc, that's a
Okay.
disc, that's a disc, that's a disc, that's a disc. And then this is the tumor. This is what's called the vertebral artery. So what's that is it's a artery that supplies the blood flow to part of it. There's like 4 main blood vessels that go to your brain. That's one of the 4 there.
So it
and
is
so the
stopping-
tumor, yeah, and so the tumor is wrapped around that
Oh my goodness.
that one artery. So that's like the big major thing for that area
Okay.
specifically.
Well, how soon can we have surgery, you know?
So, well, before we do that, I'm gonna tell you what we're gonna do, because I think that'll give you a better idea of kind of what to expect, and then basically we'll talk about kind of logistics of what needs to be done before we can do surgery to make
I'm
it
just
as safe
tired.
as
I'm
possible.
tired of going through pain, man. Like when I get out of the bed, I had to pick myself up with one arm, cause my left arm don't work, and it hurt my neck. Like I ain't never realized my head. I ain't never realized my head was so heavy. My head felt like it's 30 pounds when I'm trying to get up.
Yep.
I get up.
Yep.
Oh.
Yep.
Yeah, my head feel like it's 30 to 50 pounds, man.
Yep, and you're gonna feel it's gonna feel even heavier after the surgery. Just so you know. The reason is because it's wrapped around the muscles that help to provide the stabilization for you to kind of move up and down. So that's one of the things that you just need to be kind of cognizant of. If that feeling, that's normal. For patients who have this tumor, that is.
I'm gonna be able to get my left back.
Will you get that? Will you get strength back? You'll get some of the strength back. Will you get it all back? Not
I don't
necessarily.
need all of that back. I like shooting pool, man. I just need enough to stroke the stick, man. It's just, you know what I'm saying? It don't take a whole lot of weight to hold no pool stick.
Sure. But the coordination is probably part of the thing, right? It's not just, it's the strength of it, of getting up is fine, but being able to control it and to move the stick around, that's the part that's going to be a little bit more difficult. And so usually what we have you do is after you get the surgery and the radiation and everything else, we have you do physical therapy and occupational therapy. And what you can do is you can say to the physical therapist, I want to be able to hold the pool stick and do this. So can I work on the muscles that will help me to stabilize and do
Yes.
those things?
Yeah.
And that's something that, you know, you can definitely work on over time. But it's not something that it's just you're gonna have surgery. This is not a situation where it's
Yeah,
like,
it's gonna go real fast. I got you.
Yeah.
I understand.
you know what I mean? So the short thing, so different options, and I already know we've kind of gone over these options, but just to reiterate them again. Option 1 is we can do nothing, which we're not going to do. Option 2 is we can do conservative management or kind of symptom management, where we kind of have you see somebody to control the pain. That's not necessarily the best option. Option 3 is we can do radiation alone, which we already explained the reason why you don't do
It ain't work. We already tried that.
Yep, and
They tried that. It's like it took the inflammation out, but you know it swelled back up like a.
Yep.
It pumped back up like a balloon, like I don't know.
That's the
over
cancer.
time.
Yep, and like I said, I'm just going over all the different options again, and then and so then the option 4, which is what we would think would be best, would be do surgery and then followed by radiation, and then either the chemotherapy or the immunotherapy, depending on kind of what the markers come back as. So surgery, what would surgery be? Surgery would basically be a procedure with Dr. Tamke. He would go in. On the left side of your neck, we would go in, find where the tumor is, dissect it free of all of these blood vessels here, come all the way around, dissect the tumor out laterally here, find it where it is on the bone here, and then what I would do is go in and basically take the bone, or basically drill off the bone and the area where it's affecting, which should be all the way to here, I would say.
You said drill off the bone?
Yes, in other words, I would remove the bone and remove the tumor in that area.
Okay. So,
Go ahead.
no, go ahead. You're the surgeon.
So, no. So what we would do is I would drill off all the bone in this area, drill out this, and we would remove this tumor. And the reason why I say drill off the bone is because this is invading this part. This is the bone here. This is what it should normally look like. See how it's rounded here?
Yeah, and
Where
it's
the tumor
not.
is, it's eaten away all this bone.
Okay, I
So
see.
because it's eaten away all that bone, I would basically take out this in order to get rid of that tumor in that area.
Okay.
The issue is that right here where this vertebral artery is, that's what we would be concerned about, and that's what we'd have to find that on the backside of the tumor and see if we can preserve that. So usually before surgery, what I try to do is to have, I have the my neurovascular colleagues basically do what's called an angiogram, where they go in and they cut off the blood supply to the tumor so it doesn't bleed as much. But then the other thing is sometimes they put in what's called a stent into that, and what that does is it keeps it open so that way when we're dissecting off the tumor, we can kind of go all the way around it.
Nice.
And keep the blood flow
And
going.
keep the blood flow. Sometimes what they have to do though is sometimes they have to sacrifice it, and so they'll do something called a balloon test occlusion, where they'll basically see if we basically got rid of it, if that will do it. In this case, I don't think that's necessary, but sometimes if we have to sacrifice it or basically get rid of that blood vessel, and then basically it's just the other 3 blood vessels is what you depend on, they do that as well. And that's just something to kind of know about overall.
Okay.
So what you're saying is you'd have to sacrifice that one blood vessel.
There's
But
a possibility.
it's a possibility.
Yeah, there's a possibility.
So, but he has other blood vessels that can
Correct.
suffice.
Correct.
So he'll be okay.
And
So
that's-
that those nerve endings and everything will keep
So-
living.
So that
Okay.
right, and so the reason why we do that angiogram before is to basically make sure that with the other 3 he'll be okay.
Okay.
Meaning that if we do that test, that angiogram, and they do a kind of like what's called a it's called a balloon occlusion test, is that if they do that test and you're not fine, you're having problems like speaking, you're just not doing well, then that means that we cannot sacrifice that. And so then it would change what we would do in the OR. We basically leave some tumor behind. Instead of trying to take the whole thing out, we may leave some tumor behind so we don't injure that vessel because you need it.
Gotcha.
Does that make sense?
Yeah.
Yes.
So that would happen before.
Okay.
And then the other part of it is, and I'll show you. And then the other part of it is we put something called a cage in, or a bone graft. And what that would be is that this place where it's eaten away, if we just took this out and left it alone, you just have a big hole in your spine. And if you have that big hole, the likelihood that you would cause a fracture or collapse of it would be high. So what we do is we put in something to hold everything together afterwards. And so that thing that we put in to hold everything together afterwards is usually called a titanium cage. And that titanium cage that we use is just to make sure that everything is stable. I guess is the best way for me to put it.
Cool.
And so the better, let me see if they had, I think they did this one.
How soon do you think I'll have surgery?
How soon could we have it?
So I've been already waiting because they didn't tell me I didn't see you till.
Sure.
So I sent the message and they told me I had to see you right. So I already been waiting like 3 or 4 weeks in pain when I could have.
Sure. So so basically the surgical date I think that we have